saying something.
Hi, Dr. Manish. Nice to see all of you here.
I think we can.
Should we get
Yeah,
started?
yeah.
We'll get started, I think.
Okay.
Rajesh?
Yeah. Hi. So, hi. Good afternoon, everyone. Hello and welcome. For those who don't know, let me introduce myself. I'm Dr. Rajesh, and I work as a consultant intensivist at Cloudphysician Healthcare. So, I'm happy to announce that we are back with the second session of medical law and ethics. We have made certain changes in the how we conduct the session. So we actually taken a few topics, and the discussions will be on those topics primarily. Of course, there were many questions from the audience, and I'm sure those questions will not go unanswered. So please feel free to ask any questions, whether it could be related to medical negligence or something else. We are more than happy to answer all your questions. So let me don't take much time and get away with the session. So to begin with, let me introduce again Dr. R.K. Mani, who is Director and of Clinical Services, Pulmonology and Critical Care at Yashoda Hospitals. And we have Ujjwala Ballal, CEO at Aveksha Hospitals, and she is an advocate by profession, and her field of interest is medical law and ethics. Thank you, sir. Thank you, Ujjwala. We'll continue the session. There's one more doctor supposed to join, but I think Dr. Sumit Ray is not yet here. He might join, so we'll continue the session with this. Over to you, Ujjwala. Yeah, thank you.
So good afternoon, everyone. I think this is in continuation to our last conversation, and I think there are a few realizations that we're keeping the conversation not as long as I think last time we did it for an hour and a half, and this time we're limiting it to an hour, and then maybe continuing with some Q&A for the people who are interested. So jumping right into the topic, medical negligence. To give a pretext or a context to everyone for this conversation, if any patient wants to get redressal for his action for something wrongdoing that was done to him, the most commonest topic or the most commonest fault that they'll find is that there was negligence on the behalf of the medical professional or the service provider. So it's very, very important for all of us to understand what really constitutes negligence. How does one decide what is negligent behavior, whether there was negligence involved? I think Dr. Sumit Ray.
Yeah, Ujjwal. Just a minute. Sorry to interrupt. Dr. Sumit Ray is here. Sir, welcome. I'm Dr. Rajesh, and as I'm a critical care intensivist, I work at Cloudphysician Healthcare. So, welcome, sir. So,
thank
to
you.
everyone,
sorry to barge in, and
no,
please
sir,
go
not
ahead,
at all.
Dr. Ballal.
We are actually pleased to have you on this session.
Thank you so much.
Yeah, so let me introduce everyone. Dr. Sumit Ray is a head of department critical care medicine and medical director at Holy Family Hospitals, Delhi. Sir, heartily welcome to you.
Thank you.
Thank you, sir. Thanks. Yeah, Ujjwala, over to you. Please continue. Thank you.
So medical negligence is very important for all of us to understand, because I think as a medical professional, it is important to understand how does one prove whether there was a negligence involved or not. So before we jump right into the law, I want to start off with, in my personal view, and I believe that there are two parts to any experience that a doctor may face. And I think for everyone who's been in Bangalore, doctors have been in the news for the last 2 weeks, especially keeping in mind, starting with two unfortunate deaths that happened. One was for a patient who underwent liposuction, which was all over the news, and a lot of things have been said, and a lot of things have been put out in the media, a lot of them untrue, some of them possibly even true. We don't know that yet. So in that context, I felt that for our discussion, it's important to understand that there are two parts. That there is one when an incident happens, and what happens in the immediate aftermath of that incident, in that first 10 days or 2 weeks. And how does a doctor go about handling that, right? And that's a little bit of what Dr. Shashi and I were talking about earlier. And the second part is obviously the law, and how does one fight this case, or if there is a case involved, or if there is an inquiry or an investigation, how does one go about understanding the law and then, proceeding with action? And I think these are two distinct things, and they're very important to speak about. I personally, had the experience of in the last 2 weeks of a doctor who went through a similar circumstance, and I felt bad because I felt the doctor was very ill-equipped to know what to do immediately. What is important and what is not? Should I speak to the media? Should I not? And there's no right or wrong answer to any of these questions. And so I think I want to ask Dr. Mani this first, right? What does one do when you've had an incident? It could be something that happened maybe while during the admission, or maybe it was a complication that happened once the patient went home, but the patient has now come, typically with a huge crowd, and come and try to kind of enter the hospital and create a scene. So what does a doctor do in that first day, and then obviously in the next preceding couple of following couple of days? So, sorry, you're on mute, Dr. Mani.
I know it's a chilling experience, and it's always a very daunting experience, but one has to face. In a long career, this is these are not uncommon or unexpected. To face a hostile family, sometimes the crowd, or sometimes a hostile family with a hostile press, to confound it even further. I think when we have an adverse reaction, when we have adverse consequence in the care of a patient, preceding that, there is a way you approach. Okay, it is not just at the point of an adverse reaction. It's very important that we hone ourselves in communication. This is what I've learned to prevent these from happening, or to be able to fix up to it adequately, is to build a relationship. Because as we discussed last time, the doctor-patient relationship is not just transactional. Transaction is a small part of it. A fiduciary, a trusting, a therapeutic relationship is what we need to establish. Okay, that's very important as a basic tenet of medical practice. If you're able to do that, much of this sort of encounter may be forestalled or mitigated. But in case, in spite of all your best intentions, such a situation arises, then it is better to alert the security services of the hospital. Firstly, physically be more secure. And you don't have to make any public statement. You have to only say that anything is not culpable until proven, isn't it? That is the right of every citizen. That you are innocent until you are guilty, until you're proven to be guilty. So the process, I'm willing to be a part of the process of identifying whether there was negligence or not. We have to say that. We don't have to be self-defensive, but we can state the fact. We can say that I'm also looking into what could have gone wrong, and I will willingly accept the process of finding out, and will submit to justice if such a process culminates unfavorably to me. We have to say that we don't have to make any public statement. We should not be answering in kind in the public media that you give your story and all that, because we are not going to be subjected to a trial by the public media, by the public, or anybody else other than the law. And this is my right. So that's what I would do. But I would definitely invite the family to talk to me, even though it seems very hard. It seems as though you want to get under the table or run away. That should not be done. We, as caregivers, we should show some courage and bravery and facing up in a secure environment. I don't say that you physically subject yourself to any risk. Physically, you should be in a secure environment. That's what we do. We keep the security officers, but we invite family to talk to us, share their pain or anguish with us. We are caregivers. First, last, we are caregivers. So if the family is in anguish, it's a symptom of anguish. They go to the media or to go to the press, or they want to express somewhere, their anguish. So please express to me what your anguish is, and I'll try to answer. Because many of the times it is a misunderstanding of what is expected of a doctor, what is expected of the medical profession and the advances in science. They have unrealistic expectations, and they want to get certainty in a situation where it is full of uncertainties, and they attribute intentions to the caregiver which didn't exist. Okay, we are not willfully going to harm anybody, but harm has taken place. Firstly, just because harm has taken place, it is not prima facie negligence. Let us understand that as medical professionals and lawyers, that somebody coming to harm or dying is not a prima facie evidence of negligence. It only signals a possible negligence which has to be. We are answerable. We are not just immune to anything. We should not be. However, like any other citizen, we have the right for this presumption that we are innocent until proven guilty, same as anybody else. And we would willingly and cooperate to the legal process. This is what we should express very clearly too.
Can I put the same question to Dr. Sumit? I actually can't see him on the chat box.
Yeah, he is there. He's there. Dr. Sumit Ray is here.
Oh, yeah.
Can you hear me?
Yes.
Right, sir. Yeah. Dr. Mani answered it as well as it was possible to answer. It's a difficult situation that I guess all of us face. So as he said that, yes, make sure as far as possible to be physically secure, have people around, but also the important part is those people who are giving you the physical security should not have a body language which is counterproductive. That's also an important part of it, that builds up an aggression on the other side. Second is that when we are talking to the family who feel aggrieved, there has to be in our body language also, which is, I think, body language and is very important in this, in a direct physical confrontation situation. The body language should not be our body language. It's easier said than done. Should not be fearful on one hand, that we have made some mistake, we are trying to hide it, we are scared about it. But along with it, there should be an empathy and eye contact. Eye contact without aggressive eye contact. These are, easier said than done, but these are important things which matter in an immediate situation of aggression and violence. And that's what we are talking about now. The legal part, I think, will come later. But the immediate situation, as I said, and you have to identify within that group of people who are raising these issues, some people who are in positions of leadership within that group and amenable to suggestion. So picking up, these people and making eye contact with them and communicating with them is important. Another, I think, mistake sometimes we make is not allowing a fair number of people in that group to come in and sit and talk to you, because the restriction always be just 2 people should come in. That doesn't work actually. You should allow, say that we have physical space for about 7-8 people. Allow them to be there, because there will be different questions coming from different angles from the same family or same group of people. You have to answer those, because what happens otherwise, you speak to 2 people. One is there will be a confrontation because they have tried to stop people, right? If you allow more people to come in and sit and talk to you, a spectrum of people from the other kind of the aggrieved party, if we may call them, and they come and sit with you. If you have only 2 people, they will go back and tell something to the rest of the family and it will be misinterpreted. And another bunch will come back and want to talk to you. So it's best to deal with it at one go. If required, have 7-8 people to talk to in front of you. Have people around you who can, if a physical situation arises, can protect you. If necessary, have informed the police. I think they should be informed. They may not be right there present in the room, or they may be present, one of their representatives may be present in the room as an observer. These are important rules to set, and then talking, and never lose your empathetic, even if it is, I'm sorry to say, even if it is posture, but don't lose that, because as soon as you become aggressive and you lose your empathy, it just will go against you. And particularly in the situation where the media can be there, and I have nothing against the media, okay, they have been, to tell you honestly, for us at least during COVID, etc., they have been very, very useful. They have helped us a lot. But you have to know what will not look good on camera. All of you watch films, all of you watch television. If the body language of the doctor or the medical administrator becomes aggressive, if immediately gives a negative impression to the general public when it's going out to them. So your whole body language neither can be, that's why body language is so important, neither can it be aggressive nor can it be too relaxed. You have to sit up, be empathetic, talk confidently, make eye contact with the people, answer questions, and even some media representatives are there. If they have their questions, they may tend to provoke you. Be calm, but try to answer the questions mostly directed to the family rather than the media. You can always direct it back. If the media asks you, say that, I think the family asked this and I'm going to answer them, and be very polite. Very important not to lose your calm in front, particularly if the cameras are there. These are all important. Cameras are everywhere. You have to remember that they mostly people video record. Having said that, don't consider the people who have come to ask you these questions to be enemies from the beginning. Don't consider them. As soon as you start believing that they are the enemy, you have lost the battle. I think those are the things. I'm sure most of us do that. But just to, I think, re-emphasize, as Dr. Mani said, those of us with more gray hair have gone through this a little more. So just our experiences probably in this situation.
I agree that Dr. Sumit, it's so valuable, and I think it's very easy to forget these things in that heat of the moment, while we're facing such a situation. So I think it always helps to kind of reiterate these things. I'll come to the next situation, which, let's say this is an immediate confrontation, right? But we also often find ourselves in a position where we've treated a patient, it's been, a couple of days or a couple of weeks even, and some complication has occurred, or maybe there has been a death, or, and oftentimes you may not even remember what happened, because, there are so many patients that one treats. So what does one rely on is the notes that was written, it could be the assessment notes, the admission notes. And I want you to speak about this aspect of how and what is important, because I feel before we get to the law and before we get to entering a court and talking about what is negligence, what is the definition of negligence, what does a doctor do on a day-to-day basis to make sure that if ever there was a complication with this patient that he or she is treating today, and if that ended up in court, what is important, what is relevant, and what is scrutinized? Can I put it to you and then to Dr. Mani? Okay.
One is that documenting, we document treatment, that give this antibiotic, whatever, What we do not sometimes do in the documentation is the rationale why we change something. The rationale has to be, particularly major changes in medication, etc. The rationale for treatment change is not documented. You believe in your discussions amongst each other that, this should be done, but the rationale, even suppose just in a critical care situation, an antibiotic has been changed, okay, which had a side effect like a carbapenemide that caused seizures, right? So why did you change the drug to this from the previous one? What made you do it? Documenting it is important, that what made you make that change, right? Because you will not remember when it goes to court. The other is next to the immediate situation, that as you said, 2-3 days later, or the patient has been, is whenever you are going to meet the family, make sure you look at the file before you meet them. Make sure that you know the numbers, you know the labs, you know the patient well, because there are many patients that you said, but I try to meet the patient's family only when I'm sure that I've seen the file again. I may be seeing this patient for 15 days, but today's reports or yesterday's reports, I need to remember. And that helps a lot, because if you say, I don't remember this, in an agitated mode, the family will say, you don't know anything about the patient. And if you can give them, and I don't know if the other experience also, Dr. Mani, is that if you can give them numbers, investigations, etc., like that, and say that, 3 days back, this was done, this was the report, and this was what happened, and then we did this, and they may not remember these things, and immediately they realize that it is somebody who knows what he's doing or she's doing. That makes an immediate. So I'll just give you some of our younger colleagues say that, okay, give a blood, just recently happened. So we need a consent for blood transfusion, when to get a consent. So the family asked, what is the hemoglobin? So he had seen 15 patients. Okay, he's a DNB student. He had critical care. He said, I don't remember. The family just lost it. And he came back to me that the family is very aggressive. I said, what happened? So this happened. He said, you have to remember, you are asking for a consent for transfusion. You need to know the hemoglobin. If you are asking for consent for, platelet transfusion, you need to know the numbers, and probably 3 days numbers. Like, what has been the trend and why are you giving it, right? So there may be somebody says that hemoglobin is 7, and I know that I've read that 7 is not, I know if it's above 7, it should not be given. You say that the trend. So these things, these details are important to remember, particularly one, when you're going to get consent. Second, in subset of families which are asking you more questions, and they have the right to do that. And that's the other thing that we have to emphasize to ourselves and to our colleagues is, everybody has the right to ask you questions. And even for public health systems, that's the other problem. Our public health systems feel that because treatment is free, we are not accountable. That's not true. That has to be reminded to everybody, that just because the treatment is not free from your side, the treatment is free if it is by people's money. Okay, it's government money, which is people's money. You are not giving free service. So, and even if you give free service, you are accountable to the quality of healthcare you deliver. So this has to be reminded to our public health, people working in our colleagues in the public health system also. And for us, we are accountable to them and to answer their questions. So it's important that we remember these things. Sometimes you make notes. You have a small, like my resident, I make them write down each patient's number, general important points, so that when they're counseling them, they know those patients. You may not remember, as I said. So sometimes when you do not remember, if you give a certain amount of information and you remember, don't miss out on 1 or 2, families understand. I mean, all of us who practice, 95% of the times, families accept so much from you. They accept whatever you are saying most of the time. But if you turn out to be, not being able to answer certain aspects of their questioning, then it's already starts turning negative, these aspects. Anything else you wanted me to know, speak about? I think I spoke too much.
There's one thing which I wanted to ask you about,
Sure.
which is negative history, right? In terms of the absence of certain things, which especially becomes important in an emergency situation or in an ER.
Right.
And this is something which we have seen in many cases where the doctor says, but this was not there, but there's no record of a negative history.
You're right.
Many
No,
cases have touched upon this aspect.
yes, so that's a very important point. Yeah. So I didn't know what this discussion was going to be
Fair
about.
enough, yeah.
But yeah. So of course, again, history taking and daily document. History taking is another thing which probably over a period of time we are doing less, and particularly, we should be doing more. Particularly in intensive care, where we have become. I'm also an intensivist, so the tendency is we are so dependent on technology and numbers that sometimes we don't take detailed history. And even during our rounds, we expect less and less of the detailed history. We tend to react to situations rather than looking at the bigger and the longer picture. So that is a tendency. And as you absolutely rightly said, negative history of certain important facts and documenting detailed history of even positive facts and negative is absolutely of essence. And I keep telling my residents that whatever you say does not matter in the court of law if you have not written it. It has to be documented. And that's another thing, just to re-emphasize that The fact is, why are you changing therapy? Is very important to document. The reason for changing it, that you got a culture positive saying this, that is why you changed the antibiotic. Because then you can justify the change in antibiotic even if it caused a side effect. So things like that.
Fair enough.
Very important.
Thank you, Dr. Sumit. Dr. Mani?
Yes, very important aspects of patient care, and Sumit has told us actually from his experience, from day-to-day experience, from the ground. Okay. So what I believe is that the intervention that's so important and much neglected is communication. Okay. What has happened is to our postgraduate, graduate and postgraduate teaching and procedures, okay, medical interventions all the time, but we assume that communication skills are just but through the process. Particular training directed at communication. For instance, any patient into the critical care unit, we must have a family meeting in 24 hours. Okay, within 1 or 2 days, have a family meeting, because most of the time the patient is not communicate directly. We have to in 90% more the family on behalf of presenting the patient. So there are rules of the game in communication. Aim at building a relationship. Okay, aim at building a trusting relationship. That's very important. Both to be able to gather information, which is, as Sumit said, it's not enough. Just look at the lab details and the imaging details and the medical facts. Whole of medical evaluation begins with proper history taking. Gather information, the story that led to this admission, and also other relevant, socially relevant, emotionally relevant things that the family wants to share. These are very important, so that you can provide information. The third very important point in information sharing is that you provide medical information, provide at the first sitting what we are dealing with and what we can expect, how long it might take, and how uncertain the course is, what the cost might be, so that you establish information sharing and build a rapport. So on this foundation, you can communicate. Okay, firstly, it helps to make medical decisions. Secondly, if something unexpected happens, then they can look towards somebody who they've established a relationship, and the whole outlook is different. Okay, talking to a stranger and talking to somebody you have come to understand as a caregiver. Then how to break bad news, how to break adverse event. That's again a skill to be learned. As I said, communication is a skill to be actually incorporated in your training. When there's something unexpected has taken place, the first thing to do is honesty, of course. Honesty and transparency is looked upon very favorably by law, that you know. Okay? Any cover-up act is not looked favorably, isn't it? So factual communication, documentation, okay, and understanding from the patient what they've understood from the family. Okay, I have delivered this information. What have you understood? Last time we talked about ask, tell, ask. Okay. Ask what you've understood. Tell what the gaps are. Then in the end of communication, ask again what they've understood. So that these are now well-established techniques. I'm not saying something new. So we improve our communication skills every time we have a situation like this, and this can be done. Over years, I have learned to invest time in communicating with family. I communicate with virtually every patient's family in the ICU. It's a time well invested, okay, so that it gets less complicated along the way. As you said, history taking is not just about what the positive events have taken place. The negative history is very important as well. Okay, what isn't there? Okay, there is no history of smoking, for instance. There's no history of diabetes, for instance. So these are important negative history. We are not seen to be transparent. We are not seen to be honest if we don't document. So document is for two reasons. One, Sumit said, you are well up as to the clinical course of the patient, and it infuses confidence in the family to know exactly what is going on. Secondly, the case note should reflect what you claim you on. To reflect that. What is the present condition? All right. What is the change in the present condition? Which are required in everyday notes taking. So what I'm trying to say is, in the process of family, process of you build into certain safeguards for okay, and your own defense in case something should come to court. Hello?
Yeah,
Is the
sorry,
net
Dr. Mani,
working?
I'm facing, yeah, and I'm facing some internet issues actually, which is
Well,
why
I
I've turned
hope
out of my
you could gather the gist of what I was saying.
Yes, I did. I just dropped off for a minute there. Now I think we'll get to the main part. I'm sorry, my video is switched off. I'm facing some trouble with my internet. Am I audible?
Yeah, Urjula,
You are, yeah.
Actually, Shashi just raised his hand. Maybe we can let him ask his question. You're on
Shashi,
mute,
you're mute.
Shashi.
Okay, sorry. That was good about communication, exact details of the ask, tell, ask processes of communication and things. My question is more about, this is a tedious process. Sometimes we take 2 to 3 hours of our day, 8 to 5, looking after patients, and 5 to 6 hours discussing with the family and process. It may be an extensive number of patients which you're looking after. My question is about writing this down. How much of this, I mean, if it is critical, we need to write it down. That is okay. How much of this has value if it is all written down in detail? And is there value in actually making the family write down a number of these things? I do that for a number of on occasions when I feel that it is important, not only because they may come into a litigation or anything like that, but making sure that they have understood what I am speaking.
You see, Shashi, I think
you're on
the
mute.
question about how to allocate time. I mean, that is something which we are doing. We are doing time management willy-nilly every day. We can't be giving exactly the same time to every case. There are some which are sensitive, which are risky. Then there you spend a little more time. That's natural. You can't be spending exactly the same time between, say, 10 patients. Okay, there are some that are prioritized for more intense communication and documentation. But what I'm saying is, you can identify the difficult cases, the potentially risky or potentially litigious cases, or where decision making is a little complicated. It's not very clear cut. It's in a gray zone. Because there are many cases where the decision making is not a big deal and communication not a big deal. You have a lap chole being done. I mean, what is the big deal of communication there? No. But you have a complex case of sepsis on a ventilator. There it needs to be more communication, more complex exchange of information sharing. And we must do that, of course, in simple language. I must add, another very important tenet is simple language. Don't use jargon. And if you happen to use, please explain it. We don't have to share too much of numerical data, right? BP today is 139 by 80, and yesterday it was 141 by 79. This is not required. It confuses them because they are not able to contextualize it. They're not able to understand it. So we can give the gist of what has happened. The BP has been stable. BP is not worrisome, okay? And the heart rate may be a little bit high, but I'm not worried about it. they want the interpretation rather than exact heart rate. Yesterday it was 109 and today it is 123. So, and similarly about see, hemoglobin, I agree. 7 is the usual cutoff. So that's why we want to give transfusion today, because it has come down from 8 to 7. But we don't have to share every day's leukocyte count, for instance. It confuses them. I have seen families only talk about leukocyte counts. They get hooked on it. Okay? They tell you, he was improving. It was 15,000 and infection came down to 12,000. Infection came down to 12,000. But today to 13,500. So you see, we have overshared an information without giving them any contextual clarity. So our duty in communication is not to get them hooked onto these numbers. Rather share, you understand. You are the expert. You're supposed to interpret and tell them in the language they understand. So we must do this. This communication intervention is as important as setting up a hemodynamic measurement, for instance. All right, maybe more important, or adjusting carefully your ventilator parameters. Because what we do is we have neglected one dimension of our relationship. The dimension is, if you don't communicate, you might get misinterpreted. You may have difficulties in arriving at decisions even. So it impacts on outcomes. So that's why I said you allocate a certain time for family communication. I don't call it counseling. I call it conversation. Okay, but more even, so less of power gradient. Okay, we should lessen the power gradient so that they feel they are among friends. That's very important art of communication with the family. If you can do that, you do reduce a lot of distrust and a lot of misinterpretation, and it aids your decision making, consent taking, and also I'm sure will minimize lawsuits. These studies have been done elsewhere in the world. Good communication has resulted in fewer lawsuits. Okay, now I'm extrapolating to our cultural milieu, but we need to test all these things. We are not even thinking of research on these lines. We ought to be doing them.
Just to add,
yes,
yeah.
if you want to say.
So I think Dr. Krishnamurthy asked about, do you make them write down? I don't think that would be necessary and has any significant extra value. I mean, legally, I don't know if that has any extra value. I think you documenting it while explaining to them, and the communication and what was explained is probably of value, but but I think making the patient's family write it is of not of any legal value. Second is, as Dr. Mani said, yes, I spoke about being aware of the patient's specific numbers. As you rightly said, you need to know the balance between certain specific numbers you need to remember and communicate, and certain general trends you have to give. And exactly as Dr. Mani said, that people get stuck on certain numbers also. So, and that's the whole the thing is that when people say that our profession is looked at differently, the way our profession is looked at is very different from others. Why it's so? The reason is that we are the supposed experts who are interpreting the situation to the layperson, which is different from many other professions. I mean, lawyers would be similar, I guess. But so our responsibility is not like delivering healthcare, even in a privatized setup, is not like selling soap. It cannot be. It cannot be like selling television or soap. You cannot equate it. Even at the moment you start equating it, that's an absolute recipe for disaster, because nobody has to interpret for you. You just see the ad and buy a television. But as a healthcare professional, you have to interpret daily the medical condition of the loved one who has been given, in a sense, almost given over to you to take care of. So that is important that we realize. Remember that. I'm sure we do, but I just a re-emphasis on that. And as you and I think particularly specific to your question, I don't think documenting, making the relatives write it is of any great benefit anyway. Your documenting certain main points that you have discussed is important. Sometimes I think, I don't know if Dr. Mani will be, these multidisciplinary meetings, the complicated patients have the multiple teams who are seeing the patient together, sit together once in few days and meet the family together, so that there is no lack of communication, because with the super specialization, what has happened is the neurologist will say something, the nephrologist will say something else, and we as intensivists will say something, may say something else, which would be counterproductive to what is being explained or interpreted by the family. So sitting together in after a multidisciplinary round, sitting together with the family as a multidisciplinary team and talking together also is extremely important, particularly in complicated cases. And as Dr. Mani said, those cases where you are possibility of more litigation, etc. is there. Not just that, more complicated cases where communication is difficult because of the complexity of the disease process.
So, I agree, Sumit, that multidisciplinary, communication is so important, because studies have shown that consistency of information provision of information is extremely important for patient satisfaction, family satisfaction. This is a fact. Now, we are most inconsistent. Nurse says something, the junior doctor on duty says something, the primary physician says something, the specialist, neurologist is saying something else. Now, we talk about communication. Communication within the caregiving team is another art which should be very tactful and which should be meaningful. We must first have a good consensus within the treating team. It's easier said than done, but we have to strive for it. We have to have this consistency, and then as we get used to this kind of a interactive management, we will see its benefit. Then it gets easier with the family. If there are 3-4 specialists saying similar things, and then we can get on from there to decision making. We don't get stuck on controversies. This is extremely important. I think the sum and substance is that we must see whether there is adequate communication, there's adequacy of generation of information from the patient and family. Okay, what they want to understand and what are the values, particularly in end-of-life care. You want to know what their thinking is. They want to keep fighting till the end, or they don't want to do that, or they have some other take on it. So, this sort of a platform should exist where we have a dynamic, relationship of information sharing and decision making.
In fact, I recall a case law actually where there was a patient who had low hemoglobin and was being posted for a surgery, and they advised the patient for blood transfusion. The patient said he does not want blood transfusion. They proceeded with the surgery, and there was a complication. And in court, what they said was the patient does not understand the implication of refusing to do that blood transfusion. So it was actually the duty of the doctor not to proceed with the surgery when the patient denied. I mean, this was particular to that case. But what I was, trying to, in continuation to Dr. Mani was saying, it's not only about whether the fact was communicated or not, but whether they have comprehended the consequence of what you have communicated, the facts of denying or of approving a particular treatment. Oftentimes, doctors will say, we have explained all the risks, but explaining may not only be enough, but making sure that they understand and have comprehended completely what those risks entail becomes the question really that eventually falls in, to be answered. I'm going to come to the crux of the very definition of negligence. And many doctors have asked me this: who decides whether we were negligent or not? I have done a session, in fact, for everyone here where we've spoken about the technical definition of medical negligence. We've spoken about the standard of care, Bolam test. We've spoken about all of that stuff. And I don't want to get into the law part of it, but I'm sure this is a question I've heard repeatedly, many doctors asking, who decides whether I was negligent or whether what I did was negligent? And I want to ask Dr. Mani this question because, yes, please, Dr. Mani.
You see, Ujwala, I think negligence is a breach of the duty of care. Okay, that brings us to the question of what is duty of care. So, obviously, in this doctor-patient transaction, shall we say, or relationship, there is a something called expectation from the patient, and there is an obligation on the part of the caregiver, which is the duty of care. That is to act in beneficence and in non-maleficence, okay, and act also respectful of patient autonomy. Okay, so it's again based on ethics. So to act in beneficence and non-maleficence, that means you are acting in an informed manner so that the benefits outweigh harm. And you have to discuss the benefit and harm as a part of the autonomy, patient, respect for patient autonomy. So there are three things involved here. We have to be properly informed about what we are doing. So whether it comes in the ambit of our experience and specialty is one aspect of that. And number two, whether you have properly informed the patient of the potential harm, which means that you have opened up the conversation for somewhat shared decision making. It's not just for end of life care, it is for everything, because you can't take consent without providing proper information and making sure the patient understands. So consent is a prerequisite. And as a prerequisite for consent, beneficence and non-maleficence and opening up the conversation is important. And documentation, these are important. When do we stray from this duty of care? Well, that's the next question. When do we stray from it? And who decides we stray from it? That's where the test of negligence comes in. Just the fact of harm occurring or death occurring itself is not equal to negligence. This has been reiterated by the Supreme Court many times. I think in the landmark case, Kusum Sharma versus the Batra Hospital, this was first enunciated very clearly in court. And more, I don't remember the other case laws and names, but it has been repeated many times. Okay, so it has to be in accordance with a certain standard of care, and the standard of care doesn't have to be the very highest. Standard of care has to be of the ordinary level. So who decides this? Ultimately, a medical panel. The court appoints a medical panel, and the medical panel, and you, in your defense, you can show whether you've been aligned with the standard of care. There are certain prima facie cases where, the test of negligence is very clear. We will go, that is the next part of it. But on the face of it, this is what I understand of negligence.
Fair enough. Dr. Sumit, is there anything that you'd like to add or talk about? Okay, so, I think when we talk about this medical panel, you brought up a very interesting kind of Pandora's box, right? And in the past, I think medical panels have been, typically only from, the government sector, and, there is, I'm talking historically, and I think many doctors have always been upset that this is not the standard of care that we have always been following, and there's always this kind of me versus us, or that sort of a feeling. And how do you feel that today the medical community is not one, in the sense that is not united always? There's no one, it's not a plus B is equal to C kind of an answer. There's always a context, right? So how does this medical panel go about understanding the facts? Or, I'm just, I don't know if either of you have actually been part of a medical panel, but I think you might be familiar with a little bit of how they go about any investigation or interpreting the facts. And I wanted you to speak a little bit about that.
See, I don't think medical panel is a final arbiter. Medical panel is expected to give an opinion, which the court will weigh as part of evidence. It's not whole of evidence. The respondent also has the right to their defense and show the facts of the case. Supposing a complication has happened at surgery, something has been cut, okay, and that led to various complications, resulting in ultimately in the death of the patient. That happened in the Kusum Sharma versus Batra Hospital. The pancreas was cut during some surgery. The issue is just the occurrence of this event doesn't prove negligence. Such a complication is documented to happen up to 5% of cases. In a difficult situation like this one. So what can happen, doesn't prove your negligence. If something you have done grossly out of the recommended procedure, okay, and that the medical panel can give their opinion on, and you can also see the whole of medical literature is a medical expert opinion. So you can dip into the medical literature, and then you can submit that as evidence and argue your case. So I think the system is quite fair, and it's not against the medical profession. So we should accept this and then meet with it according to its requirements. If there are issues raised by the panel, you should be able to again give a rebuttal in a proper way based on evidence.
Okay, I'm not sure if Dr. Sumit is still there. I think he got it. Yeah, you're on mute, Dr. Sumit.
There, I just changed because again I also had internet issues, so I changed my connection. Yeah, right.
Anything that you'd like to add, Dr. Sumit? Otherwise, I'll open it up for questions.
No, please put it open for questions. I'll just give me 1 second. I'll join you back in 1 second. Right.
Sure. I'm just gonna go through and see if there's any. I think someone asked. Sandeep has asked, will audio-visual recording help? I'm assuming this is of the counseling. I mean, sorry.
Part. Yes, that's what I.
I'm not sure. Sandeep,
let's see what Sumit says about it. Audio-visual.
Just give me 1 minute. I'll just join you.
Sure.
I think making it a routine, audio-visual is not a great idea. It is for certain special situation. For instance, you are counseling for organ donation. It's very important. Do you have a recording, or sometimes you have a difficult situation.
What was the question?
As you mentioned, the hostile family. That those things, sensitive situations may call for a recording, but not routinely. I think that that's a bit of a barrier. And you have to mention that something is being recorded. You can't just do it surreptitiously.
Yes, Dr. Sumit, to just update you, the question was: with the counseling session being recorded, the audio video being recorded, would that help?
I mean, the legal position, I don't know. Actually, the probably Dr. Mani or you would be able to tell better. In terms of, is that yes, you have to inform as Dr. Mani said, that you have to inform the family that you're recording it. But can it be used as evidence? I think it can be used as evidence, right?
It can be as evidence to the extent that this information was communicated to the patient.
Yes, that's it, exactly. Not that it was negligent or not, that the information was communicated. That would be useful. To tell you, I mean, there has been only one hospital. I worked in, this is my third hospital actually. I just worked in one hospital for a very, very long time, where there was no recording, and we don't record here also. Video recording we don't do in this hospital. Briefly in a hospital which I was there previously, they used to do it, but I didn't think it made any difference to patient communication, to tell you honestly. It didn't make a difference to patient communication. Did any of those end up in court where we had video recording? Fortunately not, so we don't know if that was of use or not, but that is a legal position, as you said, that probably useful as far as it explains that the consent was taken and explained, things were explained to them.
I mean, the only other situation could be where if there was a situation where the the patient's family got violent, or so to that extent it's the proof of that, if that happens, of course. Having said that, I mean, so I'm the hospital that I work with, we've been partnered with or we work with Cloudphysician for many years now, and we faced several incidents of communication or patients being upset with us prior to working with Cloudphysician. And even though we have a team that is a tele-ICU team working with us, we never faced a single incident after working with Cloudphysician, primarily because of the way the communication and the counseling has happened. So I really strongly believe that it's not really the audio, video, or the proof of the communication, but the way the communication was done, and to kind of calm that situation and make them understand what's happening. And really that helped more than anything else. But of course, as far as the law is concerned, it doesn't hold much value beyond the fact that that communication was given to the patient's family. Are there any other questions?
Shashi has a question.
Actually, yes. I mean, when you're mentioning about medicine or intensive care, the way in which we practice, see, I mean, if I think about it, there are a number of hospitals which are fairly resource limited, and not only infrastructurally, but also I would say knowledge-wise, knowledge gaps, skill-wise, everything, they might be resource. And we do provide a service where we tell them the right things, what to do and how it can be done. Will the receiving hospital or the doctors who are now aware, earlier they were not aware that they need to do the next step beyond what they know. Now they have become aware of it, but they don't have the skills to do it. Where does this put them? Because it ends up getting documented. It gets documented very well that it needs to be done. And there is not much time for these patients to be sent out because they need that procedure or something like that. What does law, I mean, essentially, where does
if I understand the question right, is it got to do with the lack of a particular facility in a hospital? Is that
not only facility, but also basic skills, basic equipment, basic medications, for example, some medications which are beyond what is available at that moment. You can't really decide that it's going to come up in the next few days and get everything what Delhi has or Bangalore has, for example. So where do they stand is my question.
You see, Ujjwala, can I take this question?
Yes.
We are not expected to do the best available or by the best standards possible at all, by the Bolton rule. Yep. It's only what is available to you. You can only work within the context of what is available to you. I'm working in a remote place, and I don't have the facility for referring the patient for a transplant, for instance. I cannot offer it. Simple as that. So we have to be judged contextually. You can't be judged by the best available standards in the world. That isn't the law, as per my understanding. Ujjwala, you were to tell us.
Sure. The law uses a very simple definition for this, which is what would a reasonable man do in such a situation? And I think that becomes the standard of care that is set in that situation. What is reasonable in that context? And I think if you do not have a cardiac facility but decide to treat a cardiac patient, it would be wrong for a hospital to do that. If you do not have the license to treat a particular type of illness, like for example, you don't have an ICU setup, but you are taking a critical patient, that's considered negligence. So it's really about what is reasonable, and that is the kind of yardstick that is seen in the law. But Dr. Sumit, would you like to say something? I don't know.
No, not say. Actually, I have as many questions as anybody else. So just in this situation, I mean, let's say that it is a kind of a secondary level hospital, has a small ICU, patient is sick, comes to the emergency. The code of law says, do the initial management and shift to a higher center. You do the initial management, the patient is not shiftable. The possibility of the patient dying while shifting is pretty high. So you take that patient into your smaller secondary level hospital ICU to manage that. And either the patient never stabilizes enough to transport somewhere and passes away, or it gets delayed, and the patient, by the time that patient is shifted to another hospital, multi-organ failure has set in because of the facilities that you did not have and could not manage, rather, and passes away. In that setting, I'm also not very sure how the law would consider these situations. I mean, my general sense is that whatever I have had to visit the medical council for as medical director, I have to go for every case. There are not too many though, fortunately, that any doctor has had to face. So whatever little I have, it's that the medical councils till now, at least in Delhi, have been, at least very reasonable in trying to understand what the situation was. But when that is presented to the court of law, if it is the court of law which has asked the DMC to do and understand the situation and give their opinion, how would that be considered? Because that is always a worry which we don't have probably for bigger centers, but mid-level or a small. You see, even the absolutely small centers which don't have anything sometimes are better off in that sense, because they can immediately try and say that we don't have, we move it. It's the in-between centers with some amount of capability, which it's a very difficult judgment call. Do we keep this patient? Do we shouldn't? And they may not be keeping the patient just for monetary benefit. They may be just keeping because it's so unsure that shifting this patient may be, maybe more counterproductive than keeping the patient here. So, as you said, reasonable, as a reasonable human being doctor, what would be done? But that's the nebulous area I find sometimes difficult for doctors who work in this mid-level centers.
No, you're absolutely right. I think it's a tough question, both for the center and for the doctor. For the purpose of this discussion, I should say that whenever any case does go to court, the hospital is for all practical purposes, the doctor has to defend himself or herself, and the hospital has to defend, as two entities, right? And of course, you can choose to have common counsel, you can choose to fight together, and that's all absolutely okay. But you also will have to be recognized as two different entities, because you have two different expectations as far as the patient is concerned in terms of duties that we have to fulfill. So when it comes to the facility itself and the duties of the facility, so I think the first thing that the law always does is goes back to what is the license, what are you legally allowed to give, or what are you allowed to treat in your center, the permission that you have been given. And this is where, for example, in Karnataka, we have something called the KPME Act, and similarly, every state has a law that gives the license to practice to every medical facility and or medical establishment. So the first yardstick is always that. Have you followed, do you have everything? And typically in the past, what we have seen when you look at case laws, there has been a negligence on the part of hospitals, or for example, where they did not update their fire license, or they did not comply with fire requirements, or they did not oxygen. Even prior to COVID, this was a major issue where, you have oxygen plants not being maintained well and oxygen not being available itself. Blood is another major, point of contention, where there's been several cases of blood not being available, or, mistakes happening in these kind of scenarios. And these are all, when you look at historically speaking, there has been very gross negligence when, a hospital has been found guilty. And it's never been an unreasonable expectation from an hospital where you cannot shift a patient but you continue, and it's absolutely fine. I don't think no lawyer or no judge would find a doctor or a hospital guilty of negligence unless there's gross negligence on behalf of or what they should have done.
And I completely agree with you, Jwala, that I think, for all the discussions and the worries we have, and we do, and there is litigation more, when hospitals and doctors have been found negligent, it has been gross negligence. The data, the evidence shows that. And actually, even now, I think lots of patients, let's say hospitals and healthcare providers get away with a lot. Even now, even now, I have these discussions with my team regularly that, we sometimes, as physicians, as an intensivist, escape a lot of mistakes that we make. And sometimes it's judgment call. I don't think it's not not judgment call. I mean, judgment call is totally different. And the errors that we make, people don't haul us up as much as we should be hauled up, to tell you honestly. And in spite of this, so this discussion is important, but I think we should remember that in this country, even now, for all our whatever we think we face, we don't get litigated as much as we would be in many other places. Yes, physical violence surely is actually what is much more worrying in our country, because the access to legal recourse is less. So it ends up with physical violence. The frustrations are taken out with physical violence, and sometimes irrationally, sometimes understandably, if not justifiably. But yeah, and also sometimes, and I've written about this, is that a lot of the violence is sometimes not directly by the patient family, but certain local leaders, politicians trying to prove themselves and becoming the new dabang kind of. So it's a combination of factors. But litigation wise, I totally agree with you. But that those who have been found negligent has been gross negligence.
That's a great note to end this session. There's one question I actually myself don't know the answer of this, but I will put it to Dr. Mani and Dr. Ray in case they do, which is, will I be indicted if I refuse to manage a Jehovah's Witness patient going to surgery with low PCV, and since they don't accept blood and blood products?
You see, my take on this is, you see, our law does allow refusing to treat a patient, for a certain reason, to stabilize the patient in an emergency. For an elective surgery, for instance, I think if the patient is unwilling to receive blood transfusion, you're well within your rights to say, my conscience doesn't allow it to take you to a surgery and not be able to transfuse you. Please find another practitioner. That is there. But if the patient, Jehovah's Witness, comes as an emergency and refuses blood, and you are obliged to give other infusions other than blood and stabilize the patient. I mean, that is you cannot shirk that responsibility. You have to accept that and infuse saline, stabilize in other ways. Okay, that's my understanding. What do you think, Sumit?
Yes, I mean, that would be, acceptable to stabilize, but there would be, that's the big question. I have had one experience with Jehovah's Witness, not in India, but when I was training in the US, but the rules are totally different there. If you take consent for the fact that a Jehovah's Witness, his religious beliefs tell that you cannot transfuse, and you take consent based on his religious belief, and you do not transfuse, and the person passes away because of that, you are not held liable.
Yes.
In the US setting. In the Indian setting, I think it should work by the principles of legal, but Ujjwala, you would be in a better position to tell me, because suppose the patient is hemorrhaging badly, just giving saline is not going to help. Going in for early surgery, probably, but blood products need to be given, and the patients is a Jehovah's Witness. The percentage of people was very, very small, but they refuse to take transfusion. If the person dies and you document the fact that they needed blood transfusion and they did not accept blood transfusion, and because of that the event happened, I think legally it should not be a problem by the whatever little I know of understand of it. But Ujjwala, you would be in a better position to answer that problem.
Dr. Sumit, I don't I believe you are right, but I think I'd like to do a little more research before I answer this question.
Absolutely. I can speak. I can say whatever because I'm a dog. I'm not a lawyer, so you have to.
But you see, consent is a very basic thing. Now, without consent, you can't transfuse.
Yes.
Okay.
Yes.
You can't violate that law of consent. So I think I would think what you said is logical. Without consent,
and I'm sure, right? But considering that this is also being a video recording, I'd like to be given informed answer and come back to you.
Sure.
I've done my homework.
I mean, in the same context, I have maybe a comment as well as, I mean, in the UK, we had a lot of Jehovah's Witness, and in Australia, a few of them. I mean, it's quite clear that if there is a good explanation to the patient, if it is an elective process, there is a whole weeks before there is the process of going through consenting, going through what can and cannot be done, because Jehovah's Witness themselves have different ideas and thoughts, unless they're very rigid Jehovah's Witness where no products are given. So even recirculation products are acceptable by some and not acceptable by some in terms of for major vascular surgeries, for example. But if there's always a exception, which I understand that if there is an emergency and it is life, if we do not have enough information from the in a trauma, for example, they come in with and we do not know that there is a Jehovah's Witness, or it is not explicitly known. I mean, whether it's from the relay, oh, this person may be a Jehovah's Witness. If a friend tells that, we are obliged to actually do the right treatment, and at least there we were obliged to do the right thing if necessary transfusion, if the information was not enough. But I obviously I don't know the rules in this country. I think it should make sense to hold good that if we are saving a life, that is different, but if it's going to be a elective procedure, then we have to have a different way of looking at it. Would that?
I think Dr. Rajesh has a question. Dr. Rajesh.
Dr. Rakesh Reddy also had his hand slipped.
Okay.
Yeah. Hello. Yeah, madam.
Yes, go ahead, Dr. Rakesh.
Yeah, Rakesh Reddy. Yeah, please.
Yeah, madam. What is the weightage of video consent? Because we do daily counseling, and we don't take daily a consent from the patients, because every day we update the condition of the patient. So we keep recording that. So once the patient means, what is the weightage of that video consent if you're going to have that?
So we just spoke about this, Dr. Rakesh, but I'll just quickly summarize that the weightage of the consent would be the same as what they would have signed. So it's relevant to the extent that they have given consent. So that's the value of that video consent that they give. Dr. Rajesh, are you there? Maybe we can take yours as the last question.
No, actually, another question. I just wanted to add on regarding the Jehovah's Witness, because as I know, once the consent is not given by the patient, then I don't think the doctor would be held less for not giving blood, because it's already been informed, and the religious practice also holds the upper hand in Indian Constitution. Yes, the human life is much more valued than anything else, but once we don't have a consent, then we wouldn't be criticized or held responsible for not transfusing, and if the patient something happens to the patient.
Fair enough. I think
See,
this is an interesting
I
topic.
would think that if you override the the explicit wish that will not be transfused, override it, that would be a violation. Even if it's for life saving, if you transfuse in spite of the patient not agreeing, then that would be a violation, and you will be liable. I think later on the patient gets well, and then he says he has done something which I had refused.
I think we should try to convince people for certain things which may be medically necessary. I mean, I think we should not give up our hands that they are just refusing. I think it is possible, because if the case I remember in the US that I had to deal with along with my attending is that they actually agreed after a little while to after a few hours of counseling, that they agreed to transfusion. Actually, we convinced them that it is life-saving. I think whatever your religious practices, God will not will not take it negatively if you get transfusion. All kinds of language we used. I mean, I was very, very young at that time, so whatever I could, I was very, very this was a young person, and so they actually agreed after a little while. So just don't give up. Also, having said the medical legal consequence or the legal consequences of it, I think as practitioners, we also, as I said, the factor of empathy and what is the right thing to be done to a certain extent, I think we need to try and convince them also about the fact. We should not be giving up on it just because they're not convinced about it.
Yes, it's just fact to
Exactly. You got to
add.
keep talking. You got to keep talking. Yeah.
Yeah, the point to add is, sir, the even the negative consent is equally important as giving a consent for a treatment. So that needs to be valued. And as Sumit sir was mentioning, it's our responsibility to try to make the attenders as well as the patient understand the the severity of the disease. And if he doesn't take it, if he agrees, then we can go ahead. But in spite of that, he doesn't. Then I don't think in Indian law we are held responsible for the event which has happened. So, thank you.
Thank you, Dr. Rajesh. I'd like to end on a note that I particularly like today's conversation because it's a lot about how to not really end up in court, right? And I think that's really what we should all be going for. It's important to know the law, it's important to understand the law, but I also think there are many ways to not really go down that path. The law should be the last recourse for any person to want to ask questions. Really, at the end of the day, I think family member is just looking for answers, and I think doctors have that kind of privilege to be able to give it earlier and give it sooner, and maybe in a way that they are able to understand. And really, that's the biggest learning I think from today's session: ask, tell, ask. And I'm definitely going to take that as a huge takeaway even for me going forward. Yeah. Anything else, Dr. Mani or Dr. Sumit, that you'd like to say to end the session?
I will just say that I learned as much from. I mean, I with Dr. Mani, I always learn a lot, and from the other panelists and from you, I think this discussion for me, these discussions will be as useful to me as to anybody else. I'm not the expert on this at all. Like I would rather learn than be, so for me, it is as good a learning experience as speaking out and giving my experience. I can only probably speak as unlike Dr. Mani, who is well trained in the legal understanding of things, I still go by a general sense of non-maleficence and broad ideas, very, very broad ideas. So yeah, I'm learning as much as anybody else.
You see, much of what I'm saying is instinctual. I always believed that our understanding of the ethical foundation of practice of medicine, that is extremely important. That is the ABC of whatever we do. And, trying to bring that to the bedside has clarified many things, even though I have no formal training in law or anything at all. I mean, I must say, I plead total ignorance of formal study of law. But as doctors, we are obliged to know the law that enables our ethical foundation, right? Or doesn't enable, both have to. And if it doesn't enable, ethics trump the deficiencies in law. That's what I think. Okay, because we are dealing with human beings. We are, as Sumit has said so many times, we have to connect with empathy. And now, if you go too much by the rule book, it shouldn't be at the expense of empathy and common sense. So I hope to God that law will continue to enable us, and then we can go along with the law, in a friendly way. Otherwise, we have to protest, right? We have to protest that, no, we want to do the right thing and you're not enabling us. And we need to reform you. And you need to reform us. We need to reform you to do the right thing. What do you say, Ujwala? Huh?
Absolutely.
Okay. One isn't over the other. The medical and the legal profession must come together to do the right thing.
Yes, absolutely. On that note, thank you so much. Thank you, everyone. Dr. Rajesh, if there's anything from your side, that's it for me.
No, thank you. Thank you thank you everyone for joining us. Thank you, Ujjwala, for moderating this in. Mani sir, thank you. I think that okay. No, there are no further questions.
Okay.
Thank you, Mani sir. Sumit sir, thanks a lot. We all see you in the next month for the next session. Thank you.
Yes.
Thank you, sir.
Thank you. Bye.
Thank you.